So today I will be talking to you about aging in sexual and gender minority communities, and I will really be relying on a language of intersectionality to frame much of my discussion. Before I get started with today's talk, I did want to acknowledge that I am joining you from the traditional, ancestral, and unceded territory of the Musqueam people, and I am deeply grateful to be speaking with you from this beautiful land. I encourage everyone on the call to take a few moments to reflect on the ancestral lands from which you may be joining us. So a little bit of an agenda for today's conversation. I want to begin by introducing myself to you at some greater length and really taking a moment to locate myself as a researcher. After that, I want to talk to you a little bit about my program of research, particularly as it relates to sexual and gender minority aging. And I'm going to highlight one of the key contributions I have so far made to this body of scholarship. Finally, I want to make some room to talk to you about some future directions that I envision in my work. And I'm really excited to see what questions come of this conversation. So I'm going to begin with a little bit of a more sort of at length introduction to who I am as a researcher. As I mentioned earlier, my name is Hannah Kia. My pronouns are she and her. I'm an assistant professor at the UBC School of Social Work. Aside from my academic affiliation, I should also note that I'm a trans woman of Iranian descent. I'm a newcomer, I'm a settler, I'm able-bodied, and I'm middle class, although I was raised for much of my childhood and youth in a working class family. And I really feel like all of these different dimensions of my social location greatly influence not just my day-to-day lived experiences, but also the kinds of questions I tend to center in my work and then try to address. Aside from telling you a little bit about my social location and lived experience, I should also give you some more background on my academic and practice training. So I hold Bachelor and Master of Social Work degrees from the UBC School of Social Work. It is a little bit of a full circle situation coming back to the UBC School of Social Work as a full-time faculty member, and a PhD in Social and Behavioral Health Sciences from the Dal Lana School of Public Health at the University of Toronto. After I finished my BSW degree, I practiced for some time at a busy suburban hospital where I was primarily assigned to this hospital's emergency department, but I did float to many different areas of the hospital as well. After I completed my MSW, I did practice for some years as a hospice palliative care social worker. As you'll notice in my presentation today, I tend to bring in a lot of my healthcare experience in my research by asking myself what the implications of my scholarship are for policy and practice in healthcare. And although a lot of the implications that I tend to develop in my work are often specific to the context of social work practice, I do try and make them as transferable as possible to other health professions as well. So extending my introduction to you a little bit further, one question that folks often ask me when I talk about sexual and gender minority aging as a very salient part of my program of research is, why have I chosen to focus on this specific domain? And when I answer that question, first I reflect a little bit on my social location. I talk a little bit about how growing up as a queer newcomer, I was often fed dominant narratives around what it would mean for me to grow older. I'd be told things like I might grow old to be alone, without a community, without a family. And so a lot of my early interest in this scholarship was really fueled by a desire to challenge some of these dominant narratives and to really foreground the rich communities of care and families of choice that I saw queer and trans adults frequently cultivating in middle and later stages of adulthood. Aside from bringing in my lived experience to fuel some of my motivation for this work, I also find late adulthood to be a fascinating time in the human experience academically, because this is typically a period of time when the accumulated effects of lifetime marginalization tend to manifest in specific physical and mental health outcomes for a lot of marginalized populations. And in the domain of SGM aging, there's still a lot of work to be done to fully understand this dynamic. So on the one hand, we know that SGM adults do experience a lot of exposure to minority stressors throughout the life course. And we know that there are a number of social and health inequities that result from this exposure, but we don't know too much about the social processes that tie these two ends together. And so I am really interested as a scholar in helping to address some of the lingering questions. So let's begin talking about SGM aging as a substantive area of inquiry. First and foremost, when we talk about LGBTQ2S older adults as researchers, we're often referring to sexual and gender minorities ages 50 and over. Now, for many of you on the call, that might seem like a really low threshold, and I would agree with you in many situations. But when we remember that a lot of researchers began contributing to this body of scholarship during the 1990s, which was, I would think the height of the HIV/AIDS epidemic, and a time when the life expectancy of gay men, trans women, and a lot of other queer and trans folks was reduced as a result of the epidemic, we begin understanding some of the decision-making around reducing the threshold for late adulthood. Now, I should mention that a lot of scholars have retained the 50+ threshold for studying aging issues among sexual and gender minorities. And this is primarily in light of some of the logistical difficulties related to recruiting sexual and gender minority folks who are, say, 60+, 70+, and so on. A lot of older SGM folks very validly have a great deal of hesitation and apprehension in engaging with researchers because of the troubled history of a lot of queer and trans communities with scholars. And so while LGBTQ2S aging scholars are trying to find ways of building relationships with older queer and trans adults, they're also thinking about practical ways of continuing to grow this scholarship. And one of the considerations is retaining this 50+ threshold for the time being. Now, in terms of what the context of LGBTQ2 actually looks like, we see a couple of patterns really saliently reflected in the literature. First and foremost, we see that older LGBTQ2S adults experience an increased susceptibility to violence, stigma, and discrimination. So for many of you on the call, you might remember the 2000s and early 2010s when we had the It Gets Better campaign. We had a number of celebrities make posts on social media and other platforms talking about how conditions for them got better as they transitioned from puberty into early adulthood. And we certainly want to celebrate these accomplishments and these changes in the social conditions of a lot of queer and trans folks. At the same time, we need to remember that for a lot of people transitioning from middle to later stages of adulthood, it's not quite so simple as it getting better. In fact, in many cases, it does get worse, and we need to account for this reality in a lot of our scholarship, policy, and practice. We need to really think about how folks become increasingly susceptible to violence, stigma, and discrimination in many cases. The context of LGBTQ2S aging is also often marked by the effects of lifetime exposure to LGBTQ2S specific systems of oppression, including homophobia, biphobia, transphobia, settler colonialism, heterosexism, and cissexism, among many other factors. So we really see how exposure to these factors over a lifetime actually translate into some negative impacts on the living conditions of a lot of older queer and trans folks. So to give you an example of what this latter statement actually can look like empirically, relative to same-age heterosexual counterparts, we see that lesbian, gay, and bisexual older adults are much more likely to experience disability as well as poor self-reported physical and mental health. And we see that these health outcomes are frequently associated with lifetime exposure to homophobic and biphobic victimization. More specifically, we see elevated rates of cardiovascular disease, asthma, diabetes, depression, anxiety, and suicidality in LGBT older adults relative to heterosexuals of the same age. So here we really see how exposure to minority stressors over a lifetime can actually wield profoundly negative impacts on our physical and mental health. When we turn our attention to the domain of trans health, we see that relative to same-age cisgender LGBT counterparts, trans adults report even greater lifetime exposure to violence and victimization, and perhaps not surprisingly, even poorer physical and mental health. Now, you might notice that I haven't so far talked about two-spirit adults on this slide, and I want to just confirm that I haven't forgotten about this really critical population. I wanted to really emphasize that there's a significant lack of research on aging in two-spirit adults, and I think we're definitely in a time where we're in dire need of more scholarship around what's going on for this group. Now, there's a lot of really rich theoretical literature that really points to the possibility that exposure to systems of oppression based on gender, race, and class/poverty may increase susceptibility to poor physical and mental health in LGBTQ2S older adults who are marginalized on grounds beyond sexual identity, gender identity, and age. And yet we have a very significant gap in the empirical literature on these intersections. So moving into the future, we really need to make our scholarship more intersectional and more sensitive to how exposure to interlocking systems of marginalization might actually impact our physical and mental health in ways that we don't quite know yet. Now, so far I have highlighted a lot of the adverse social conditions and experiences that typify the domain of SGM aging. And these are, of course, really important for us to factor in our work. At the same time, I really wanted to take a moment to highlight the resilience that we often see reflected at the intersection of LGBTQ2S identities and older age. A lot of older SGM adults do have really robust families of choice, and I would say, given the opportunity, can draw on these families to develop their own communities of care. We see that a lot of older queer and trans adults have, in fact, been instrumental in constructing community-based networks of support and advocacy that we see today. So yes, this is a population that is deeply impacted by social and health inequities. And at the same time, this is a really tough population and one that has expressed profound resilience at this intersection of sexual and gender minority aging. And I think as researchers, practitioners, policymakers, it's really our responsibility to leverage the strengths of this population to think about how to address some of the inequities we do see. Aside from this point, I think it's really important for us to acknowledge the agency and resilience that's simply required to live life authentically as folks transition into later stages of adulthood. I have a really dear friend of mine who is a trans woman and transitioned in the 70s. And when I hear her talk about her experiences of transitioning, I'm just left in awe of the courage and bravery that was required of her to live life authentically during this time period and to continue doing this today. And I think these windows of lived experience are so profoundly important for us to celebrate and to highlight. So now that I have given you a little bit of a context around SGM aging, I want to speak with you a little bit more about my own contributions in this area. And, I want to talk to you about my doctoral research. Now, I understand that my PhD is in my past. So, for some folks on the call, you might think, should you not be talking about something more recent? But I did actually defend my dissertation as late as 2019. So this work is still fairly recent. For my doctoral research, I examined subjugation and resistance in older gay men's experiences of seeking and receiving care in health settings. And this was a study that was supported by a CIHR Doctoral Research Award. Today, I'm going to give you a very, very brief overview of the background that provided me with a rationale for pursuing this line of inquiry. I'm going to give you an overview of the methodological underpinnings of my research design. I'll review some of the key findings that really surfaced in my data. And then finally, I'm going to conclude with some policy and practice implications that I saw reflected in my work. First, I would like to make some acknowledgements. I would like to thank very, very sincerely my doctoral supervisor, Lori Ross, my doctoral committee members, my community partners, as well as my funders for providing so much support during the research process. I know for a fact that I would not have been able to do this study without their input, and so much gratitude is owed to them. So let's begin by really contextualizing older gay men's experiences with healthcare. Older gay men have had very complex relationships with health systems. And I would say much of this complexity is really reflected in the social history of HIV and AIDS. During the 1980s and 1990s, which I think are decades that really reflect the height of the HIV/AIDS epidemic, a lot of gay men of this era experienced profound expressions of stigma and discrimination in their interactions with health systems. And, you know, much of this experience is unfortunately unsurprising given the rampant homophobia and HIV stigma that characterized a lot of mainstream medical institutions of that period. And so a lot of older gay men today have been deeply influenced by this social history. And for this reason, often expect hostility, mistreatment, or neglect whenever they do encounter healthcare providers, as well as other actors within mainstream health institutions. Aside from older gay men's expectations of healthcare systems, we know that older gay men today actively experience subjugation on the basis of factors such as homophobia, ageism, heterosexism, and HIV stigma, among other factors. And we know that access to care is often systemically compromised for those in this group as a result. So it's really important for us to factor these things when we think about how to tailor our scholarship in this area. So based on my appraisal of this literature, the two research questions that I landed on for my doctoral research were first and foremost, how are processes of subjugation and resistance reflected in the accounts of older HIV positive and HIV negative gay men seeking and or receiving care in health systems? And second, what is the comparative significance of the HIV/AIDS epidemic in constructing healthcare as a site of subjugation and resistance among older HIV positive and HIV negative gay men? Methodologically, my study was informed by an approach to grounded theory known as situational analysis. Essentially, this involved the inductive and iterative collection and analysis of qualitative data to generate a contextually rich theoretical account of subjugation and resistance as it was reflected in the healthcare experiences of older gay men. My sample included 27 gay identified men ages 50 and over, each of whom had at least 3 experiences of seeking or receiving care in Toronto over the 12 months preceding the study. 16 of my participants did self-identify as HIV positive, and I did deliberately oversample from this population to gain insight on the influence of HIV and AIDS history in shaping older gay men's contemporary experiences with health systems. My recruitment processes were supported by LGBTQ community agencies and AIDS service organizations in Toronto. As far as data collection goes, each of my participants underwent 1 to 1.5 hour semi-structured interviews in which I asked them questions about services they sought and or received, experiences they had with healthcare as older gay men, and barriers and facilitators to care that they had, among other items. My analytical processes were inductive and iterative, as I mentioned earlier, and really had as their end theory construction on subjugation and resistance as reflected in older gay men's healthcare narratives. I did want to emphasize that I did my best to incorporate consultation with community members at all stages of my research process. One example of consultation that I did engage in was having the Toronto Senior Pride Network review my interview protocol in 2016, which was tremendously helpful in getting me to think about some of the priorities, experiences, and so on that I needed to have better reflected in my research design. And beyond that, I did do my best to reach out to folks with lived experience through my time on this network to get relevant insights from my research. So let's move on to some of the findings that I saw reflected in my work. First and foremost, when I looked at my data, one of the themes that really stood out to me was this discursive entanglement of homophobia with HIV stigma in constructing older gay men as undeserving medical subjects. A lot of the men in my sample talked about how their encounters with healthcare providers often left them feeling like they were undeserving of the care that they were receiving. And this was often attributed to what they believed were assumptions that healthcare providers made about the sexual practices of older gay men and negative connotations they attached to these phenomena. So to give you one example, our interview with Ross, a 56-year-old white man living with HIV, contained an excerpt that really, really reflected this idea. He mentioned, for men in my generation who are in their 50s or early 50s, I think it's automatically assumed that because you're gay, you live with the AIDS virus, and because you're gay, you're a slut and you deserve to live the way that you deserve whatever comes your way. Now, this kind of account, although staggering for many of us researchers, was actually very common among a lot of the accounts of my participants, and really gave me a sense of how rampant homophobia and HIV stigma continue to be in contemporary medical institutions. The next set of findings that I really want to highlight with you today was this idea that older gay men constructed contemporary medical services as socio-historical artifacts of HIV and AIDS. So many of the men in my sample talked about how because of their experiences navigating care systems during the HIV/AIDS epidemic, they had really grown to have negative expectations of healthcare providers. One of the examples that really highlights this theme is contained in our interview with Lou, who was a 70-year-old HIV negative white man. He was quoted saying, "Even if they have medication, I'd rather remain HIV negative, not positive and not have to take all these medicines and stuff, If somebody becomes HIV and all that, you can't condemn them, but you don't want that either, right? In the past, when a friend was HIV and then AIDS and all this stuff, apparently the medical department, they weren't too thrilled to take care of them." This was, again, an account that was really prominent in the interviews I had with the men in my sample. And although Lou here is talking about the prospect of maybe one day living with HIV and what that would look like, I should mention that a lot of the men in my sample talked about these negative expectations of healthcare outside of the context of receiving treatment specific to HIV. One of the themes that I really wanted to foreground for today's audience was this notion that intersections of class and race were really salient in constructing older gay men's subjugation across a lot of the healthcare settings that figured prominently in my findings. So many of the men in my sample, particularly those who were affected by systems of marginality based around class and race, talked about how they would intentionally want to minimize the visibility of their gay identity because they could not fathom experiencing stigma and discrimination on the basis of their gay identity, in addition to a lot of the systems of oppression that were already operating in their lives. To give you a sense of how this theme tended to manifest in the accounts of my participants, I can revisit our interview with Trevor, who was a 55-year-old HIV negative Black African Canadian man. He was quoted saying, "In general, I don't disclose I'm gay. I mean, I think it's just the whole thing of being judged. I still feel reasonably healthy and young, but the older you grow, the more services you get, the more racism you face, because people have less filters, you know? And so I'm careful." So for Trevor, there was this idea that as he would get older, he would become more susceptible to racism, and as a result, really needed to minimize the salience of his gay identity as a protective measure. And to me, this really reflected the intersectionality of racism, homophobia, as well as ageism in constructing his lived experience. And, you know, for a lot of the men in my sample, it was primarily systems of oppression centered around class and race that factored into this. Finally, a theme that I wanted to review with you, and I wish I had more time today, but I'm happy to field questions if folks are interested in learning more, is this idea that resistance was actually reflected quite prominently in my data. And some of this came out in some of the men's intentional leveraging of their visibility across systems of care. So in the previous slide, I talked a little bit about how some of the men tried to minimize the visibility of their gay identity. For some other men, there was this tendency to want to make their sexual identities as visible as possible in order to affect systems change on some level. Sam, a 77-year-old white man who reported being HIV negative, talked about how he was at a community consultation with a health authority, and how he actually leveraged his gay identity to use his lived experience and challenge some of what the healthcare administrator present at that meeting was saying about the suitability of services for older gay men. He was quoted saying, "We have to infiltrate the educational programming in medical schools so that the stereotypes of what's expected and what's real regarding older gay men are clearly defined." We did have one meeting at a large local hospital. We had the director of senior services in the meeting, and he told us how wonderful his services were. And I said, "Don't tell me from my own experience that I should like what you're offering." And I think he was a bit shocked because he didn't expect anybody who actually had the experience to share experience with the audience that was there. So here we can really see lived experience functioning as a form of knowledge to mobilize resistance and hopefully affect some systems level change within healthcare settings. So moving beyond an overview of my key findings, what does all of this mean for policy and practice in healthcare? First and foremost, I would say that my findings point to the importance of proactively normalizing same-gender sexuality in our practice with older adults. A lot of the men in my sample really talked poignantly about the salience of homophobia and HIV stigma across systems of care. So for those of us who are practitioners, we really need to think about how do we normalize same-gender sexuality in our practice with all older adults, regardless of what assumptions we may or may not be making about their identities. And one really concrete way we can go about doing this is by offering information on LGBTQ2S, affirming services to all patients and families. On the flip side, I would say it's also important for us to understand the importance of upholding a client's privacy and confidentiality in relation to gay identity and or HIV status. My findings really highlight just how rampant exposure to homophobia and HIV stigma is for a lot of older gay men. And you know, this really tells us how important it is for us to not only seek permission when it comes to information sharing, but also to only share information if it is on a need to know basis. I think this is a really simple takeaway, but one that really needs to be foregrounded as part of the policy and practice implications. At the meso level, some of my participants talked about the relevance of peer navigators for older gay men, as well as other LGBTQ2S older adults, and helping them to navigate health systems. So a lot of the men really talked about how having somebody with lived experience simply companion them through their experiences with healthcare providers could serve to buffer some of their exposure to stigma and discrimination. And I thought this was a really tangible takeaway around how do we address some of the systemic injustices we see at the meso level. I also think my findings really point to the relevance of training for healthcare providers on responding to the needs of older gay men. You know, a lot of my findings foreground the historical impacts of the HIV/AIDS epidemic on a lot of older gay men today. And I think we need to really think about training healthcare providers to understand the full impacts of this history on older gay men specifically. When it comes to other LGBTQ2S populations, there are similar legacies related to, say, psychiatrization and other institutional wrongs. And I think as practitioners, researchers, policymakers, we need to make practitioner training more sensitive to these historical realities. At the macro level, I really see the need for policies that mandate collaboration between mainstream health systems on the one hand, and LGBTQ2S and HIV-specific community-based organizations on the other in delivering certain services. A lot of the men in my sample talked about the profound barriers they experience to accessing care in mainstream medical institutions, and you know, the relative ease with which they access some of these same services in community-based settings. Rather than, I think, incentivizing collaboration, I think we need to mandate collaboration between, say, health authorities and the nonprofit sector to identify ways of brokering access for older gay men, as well as other older SGM folks. I would say that my research really points to the need for more inquiry on healthcare avoidance among older gay men and other aging sexual minorities. You know, this notion that older gay men tended to avoid healthcare systems altogether was certainly foregrounded quite strongly in my data. And I think this really drew my attention to how relevant it would be to grow scholarship on this topic. And I didn't talk about this too much, you know, when I was going over my methods with you, but, you know, I did have a relatively lower number of racialized older gay men in my sample than I would have wanted. And I think this really points to the need for more research on the healthcare experiences of racialized older gay men specifically, given some of the important intersectional differences among those in this group. Now that I have given you an overview of this study in particular, I'm going to move into the final parts of my presentation just by giving you an overview of some of the other projects that I'm currently a part of, and also give you a brief overview of some of the directions I see my research headed. So currently I am a co-investigator on a study that is aimed at addressing knowledge gaps in meeting the housing needs of older LGBT Canadians. This is a study that's funded by a SSHRC CMHC Collaborative Housing Research Network Initiative grant. And it is led by Jackie Gehagen at Dalhousie University. And with this project, we're really looking at both identifying and then hopefully addressing some of the gaps in research, policy, and practice surrounding housing issues among older LGBT folks. It does involve building national partnerships to identify gaps in research on housing for older sexual and gender minorities, to facilitate consultations on housing for this population, and to develop knowledge on policy and practice in this area. Currently, we have finished conducting a scoping review, a national survey, and focus group across 9 locations throughout Canada, I believe. And we are now in the knowledge mobilization phases. So I'm really excited to be part of this and to see where our work lands us as we move into the future. I'm going to give you a very, very sort of surface level overview of one of the key areas of study that I'm currently really interested in, particularly as it relates to SGM aging. One of the domains that I really want to pursue in my program of research is really a study around expectations and experiences of aging in midlife and older trans adults. There is a limited body of evidence suggesting that midlife and older trans folks experience profound exposure to violence, stigma, and discrimination. And we know that there are significantly poor social and health outcomes that are reported among those in this population relative to cisgender LGB adults that are specifically connected to their experiences of violence and victimization. And in my research, I really hope to investigate the social processes that tie these two types of experience or these two phenomena to one another. I should note that there are no qualitative studies that come to mind right now about how trans persons experience aging specifically. There is some really rich qualitative work looking at transitions in the context of later life and midlife, but there aren't studies specifically looking at aging processes. And so this is something that I find deeply interesting from my research and something that I would really like to investigate as I move forward in my program of research. With that being said, this actually brings us to the end of my presentation. Thank you so much for having me with you today.